morning. Thanks, Dr. Chetan, for that introduction, and thanks for inviting me here. It's always a challenge to have a first session on a third day, but I am happy that there are people attending, and this is a great conference which is going on. So we will speak basically in the next 15 minutes or so about recurrent metastatic squamous cell carcinoma of head and neck, and specifically the role of immunotherapy here. We know that head and neck cancer has got major physiological, social, and psychological impact on patients. There is nothing to say about that in this group. And we actually try to do a lot of things together, multidisciplinary discussions. Each patient is different. Each patient at different point of their life is different, and they need different solutions actually. So the Mdt approach, the Mdt is expanding. We are now, other than all the what is written here, we have molecular, pathologists who can help us in getting a better treatment decisions in some of our patients. So we have to always discuss for each patient. 20% of all the total tumor burden in India, and the most important thing is that up to 50% relapse happens in the first 2 years. So that is the unmet need, what we see in head and neck cancer. And we are, as a country, the head and neck cancer capital of the world. So I would say that since last 30 years, the platinum-based therapy that has been the most important or the cornerstone of treatment in head and neck cancer. And it is very surprising that there is no other solid tumor where you have an 80% response rate to chemotherapy, but there is no survival improvement with neoadjuvant chemotherapy, which is something which we should discuss and look at why we are not getting survival improvement with neoadjuvant therapy with such a great response. So when the patient progresses, the outlook of the patients remain poor, and there is a role of immunotherapy because there is an immune microenvironment in head and neck cancer, and there is scope for using immunotherapy in this group of patients. And we talk about, today we'll talk about nivolumab, the first human IgG4 PD-1 receptor blocking monoclonal antibody, and specifically about this trial. So this is Checkmate 141 trial, which actually was published, I think, in 2016 maybe. This trial looked at nivolumab versus investigator's choice in recurrent or metastatic squamous cell carcinoma of head and neck cancer in overall population, and also looked at specifically the PD-L1 subgroups. So very simple study design, recurrent metastatic disease of head and neck, different areas. The patient should have progressed on or within the 6 months of last dose of platinum-based therapy. So here I would like to spend some time. This had groups of patients who had progressed on the first-line chemotherapy, who had progressed on chemoradiation, and who had progressed on post-adjuvant therapy. So, and also patients who presented with first-line metastatic disease. So this is a spectrum of patients who were treated with either immunotherapy with nivolumab or investigator's choice, which could have been methotrexate or docetaxel or cetuximab. Primary endpoint was overall survival. This is the baseline characteristics. As I previously said, there were different sets of patients in this, and almost 60% of the patients had received cetuximab before, and primary metastatic disease was in almost 40% of the patients. So we will look at this data with relevant subgroups, and just to say in one line, was the study was a positive study. There was an overall survival advantage as compared to investigator's choice, where there was 5 months overall survival to 7.7 months, and in 1/3 reduction in risk of death at 2 years as compared to the investigator's choice, which is a significant improvement, curves widely separated, and became the accepted as a standard of care in this group of patients. Now we will try to dissect some data into it, and the greater overall survival of with nivolumab is coupled with more durable responses, which is expected with immunotherapy. We are all chasing the tail of the curve, that when you get responses and when you have a durable response, that is how we get more benefit to our patients. The only thing is that to continue the immunotherapy. And there was overall survival benefit regardless of the PD-L1 expression. This is also an important takeaway from this study, though the quantum of benefit was definitely more in the PD-L1 more than or equal to 1% subgroup. So what were these group of patients in this study? As I said, there were patients who progressed on induction therapy or concurrent platinum therapy or adjuvant therapy immediately after. So this group of patients, I would say, are the highest risk group of patients because they are almost chemo resistant or treatment resistant group. And there are group of patients who had first line therapy and progressed later. So we will focus on that group, the one who had first line like chemo resistant kind of group, where there were 78% patients who received the nivolumab. So the initial outcomes of these outcomes have been published recently. Almost 20% of these group of patients in this study had primary progression in this setting. And here actually, if you compare the outcome with investigator's choice versus nivolumab, the impact was even more, which is obvious that these patients were either progressing while on chemotherapy or immediately after the adjuvant therapy. And there the impact was, if you give the standard of care, which is either chemotherapy or cetuximab, the survival was only 3.3 months versus 7.7 months if you give immunotherapy. So if you have a patient who is progressing on neoadjuvant therapy or progresses immediately within the last line of therapy, I think definitely we should consider a change of therapy, and nivolumab actually is the standard of care in this group based on this data. There is response rate, not much actually. Immunotherapy and any other targeted therapy, we don't think too much about the response rate, though response rate is the one which the patients are looking at. But the response rate here is around 10 of the patients, 20% response rate was seen in this study. And quality of life measures, whenever we have a patient who is responding to treatment, especially a patient who has progressed on one line of therapy immediately, definitely if there is a response and if the patient's disease subsides, the quality of life should improve. So physical functioning, role functioning, social functioning, all the parameters favored nivolumab. And symptom burden was also stabilized better than the standard of care. So what was the difference when we look at the patients who achieved a CR or PR? These are not very high percentage of patients who achieve CR or PR, but if you get a CR or a partial response to immunotherapy, then the real tail of curve, what you see, you can see that these patients, if they are able to maintain the immunotherapy, the median overall survival for these patients have not reached. So this is interesting data, and this is what drives us or makes us look into immunotherapy as an option in many of our solid tumors. Even in patients who get a stable disease, where the tumors have not shrunk, the response rate is not there, but these patients also get survival benefit. The median survival with just stable disease in this group of patients was 10.4 months. And when you look at the patients who had cetuximab versus no cetuximab, in this study, I think 60% of the patients had cetuximab before. The outcomes are better if the patient has not received cetuximab in first line. Something to note when we have immunotherapy coming in big way in head and neck cancer, whether we should still continue using cetuximab in the first line. But that is not this study is not powered to detect that difference, but it is just one observation. And the improvement is irrespective of the age and HPV status. We always keep on saying in Indian context, the HPV status doesn't matter because most of our patients who are HPV positive also have a smoking or a tobacco exposure. In this study also, the immunotherapy impact is irrespective of the HPV status. And the Asian subset which was looked at also had a benefit of nivolumab. The median survival was 12.1 versus 6.2 in the other group. And the impact of nivolumab versus standard chemotherapy or cetuximab single agent was across the group without any particular group to be picked here. So the toxicity profile, we all know that immunotherapy is much better tolerated than conventional chemotherapy. There are immune-related adverse events which are seen in less than 10 to 15% of the patients, but otherwise it's a very easy treatment to take. The main toxicity is the financial toxicity which we see. So these are the treatment-related side effects, very, very typical of a immunotherapy side effect, the grade 3-4 toxicity like fatigue, nausea, anemia, asthenia in very small numbers only. And immune-related toxicities also are very in less than 10% of the patients. So the take home from this is that if you are considering a monotherapy post progression with platinum, I think with this study, nivolumab is the treatment of choice. So when should we plan initial evaluation while on immunotherapy? We all know that the first evaluation should happen after few cycles of treatment to get more robust outcome measures. So in summary, head and neck cancer can have major physiological, social and psychological impact. Multidisciplinary discussions will help to provide optimal solutions for the patients. Nivolumab in the Checkmate 141 study and the recent analysis of that particular subgroup has shown that patients who are recurrent or metastatic squamous cell cancer, the magnitude of overall survival benefit is more than 5 times in the first line subgroup. And quality of life is stabilized with nivolumab, and the Asian group also benefited much more than the others in this subgroup. So this I will not take much time into it. So this is just an example of a patient, a 67-year-old, stage 3 squamous cell carcinoma of the tongue. Initial treatment, there is a stable disease, then there is a recurrence of disease, and whether with this situation where there is a borderline renal failure also, nivolumab is the treatment of choice. And from the data we know that regardless of the age, we can give nivolumab to elderly people also. And another patient who is a lady who has got larynx cancer and treated initially with radiation and later with radiation with carboplatin and then paclitaxel, then recurs with metastatic disease after 13 months of treatment, which is another very common scenario in our approach. Here also, regardless of the type of recurrence and the timing of the last treatment, I think single agent nivolumab is one of the treatment options. And I think that's my last slide. Thanks a lot.